Great, thanks, Richard, and I hope you can all hear me. Okay, my name is Tlesla. Aje Chep Otams Je Aje, Emutas Kwananape. I'm from Tla'amin Nation near the city of Powell River, and I trained as a family doctor, but I've worked in population public health since 2007. And so looking after large groups, particularly First Nations Inuit Métis, has been my work for quite a long time, almost the entirety of my medical career. So I have lots of thoughts to share. Knowing that the care for Indigenous people is unique, a very small, unique population, but an important small proportion of the Canadian public, but also want to explode it out so that all other groups are included. A system fails, and I trained in the U.S. A system fails when it favors one racialized group over the other, and where you say, "Oh well, that group is doing terribly. Uh, that's so sad," and then to do nothing, to make no plan to make sure that everyone is coming forward. Uh, so these are very important times for Canada as we look at reconciliation with, particularly with First Nations people, but also with Inuit and Métis. I spent quite a lot of time in Hawaii, and I use that as a metaphor. When I first went to the Hawaiian Islands, and the Hawaiians call us mainlanders, and I was there with a group of physicians, other mainlander physicians. A lot of the other physicians really didn't understand that they were there in part to serve Hawaiians, to help Hawaiians, and not just the residents of Hawaii, but the original inhabitants of Hawaii, but also visitors to Hawaii. And that was interesting to me, that physicians sometimes didn't make distinctions about the different kinds of people that they were serving, and that they should and need to serve everyone. Part of our work as physicians and as general Canadians or average Canadians is that we are nation building, all of us. We have a duty to help each other and our fellow citizens. And when I was a kid, I remember when ambulances were introduced, and I remember the fight to make sure that ambulances would also go to reserves, would come to my community. And I remember one of my sisters was hurt while we were out playing, and an ambulance was called, and we all stood around wondering if the ambulance would arrive. Does the service come to our people? If you listen to First Nations people, and I've listened to literally tens of thousands of them, they are still suffering in spite of our many, many efforts to reform our healthcare system. So when I was asked to speak to you, and again, I do take these requests very seriously and thought very hard on this matter. There were a few things that I wanted to say. It is difficult to look after each other, but it is an imperative. And for those of you who look after other people, and I'm pretty sure that most of you here on this call actually do look after others, it's very difficult. It comes at a cost to yourself, but it's a very basic and core human experience to look after others. Most of us are only experienced in looking after those who are close to us. Canada is a multicultural, pluralistic success story. We have a lot that we need to learn in order to look after each other amongst all of our differences. And included in Canadian populations and included in Canadian realities are Indigenous populations and realities. And they're very particular. And I hope that you will, and the system will learn how to serve, help those people better. And I'll use the analogy of we live on the same island. We can fight over the water. We can fight over power and authority. We can fight over identity, but it doesn't really help. It's much better for us to be good neighbors with each other. And there's my 4-minute mark. I just want to say that there is a lot that we can do to make sure that what happens to others, well, to recognize that what happens to others happens to us, to create a safe environment, not an unsafe environment, a safe environment for people to receive care. And the healthcare system is meant to do good things, not bad things. And we do hear that sometimes bad things can happen in the workplace of healthcare. And I hope that we can try and rectify those. Last of all, there are already hundreds of recommendations around how to improve Indigenous health that exist in the Romano report, in the Truth and Reconciliation Commission calls to actions, in the inquiry into murdered and missing Indigenous women and girls, in the In Plain Sight report, in the practice standards for Indigenous cultural safety, cultural humility, and anti-racism, in UNDRIP, and in a number of other documents. So thank you very much.
All right, thanks, Evan, especially for that emphasis on what's already been out there and been done as this panel considers how to include this in its recommendations, that there is already a universe of great recommendations out there, and sometimes implementation or simply listening to those is part of our challenge. I'm going to turn things next to Dr. Lindsay Mackay. Lindsay, thanks for joining us. And if you can add your voice to our discussion around equitable access to care, and talk a little bit about your experience and how this group can kind of understand the context of mental health and addictions and other similar issues with respect to serving those communities in primary care. So welcome, please.
Thanks. Hi, everyone. So I'm Dr. Lindsay Mackay, and I've been providing primary care and substance use treatment in Vancouver's downtown east side since 2015. As was previously mentioned, I'm the medical lead for the Downtown Eastside Connections Clinic, which is a low barrier and rapid access substance use care treatment center. And I also currently work for Portland Hotel Society, which is a charitable nonprofit that provides housing, healthcare, harm reduction, and health promotion for some of the most vulnerable and underserved people in Vancouver. And I've also done some work as the chair of the Vancouver Divisions of Family Practice Mental Health and Addictions Committee, which is committed to improving the delivery of mental health and addictions care in primary care settings. So I've worked in a range of healthcare settings, from nonprofits, fee-for-service, health authority-funded clinics, to also entirely private clinics. And I've really gotten a good chance to see how these various models of care impact the outcomes. So about almost all of the patients I see are struggling with problematic substance use. In the downtown east side, primarily opioid use disorder. And there's also a lot of severe mental health conditions like PTSD and psychotic disorders like schizophrenia. A large proportion of the population I work with has no fixed address. And those that do have housing are typically in social, single room occupancy or SRO housing. Typically, they have no reliable means of communication or transportation and just face a huge range of barriers to accessing medical and mental health care. So speaking specifically to equity versus equality with respect to this population, as I'm sure most people are aware, equality aims to treat everyone the same, providing equal opportunities and resources. However, for individuals with mental health conditions and/or problematic substance use, equality alone is not sufficient. Their circumstances and challenges require additional support in order to have any chance of achieving equitable outcomes. Equity, on the other hand, recognizes that people have different starting points and diverse needs, and it focuses on providing enhanced, tailored support to help address these specific needs in order to ensure fair access to treatment, rehabilitation, and social support services. So if we are able to prioritize equity, vulnerable individuals can receive the support they need to overcome the barriers and achieve positive outcomes. So I wanted to give an example to illustrate a typical patient that I might see in my practice and the challenges that they face going through the medical system. So think of an individual who has severe PTSD after a lifetime of childhood abuse. They also have heart disease and diabetes. And in addition to that, they don't have housing, they have no means of transportation or a phone, and they're currently using illicit substances like fentanyl and crystal methamphetamine to help cope with their trauma. So this individual would face many barriers to accessing appropriate care for the medical and mental health conditions. They likely would also be on opioid agonist therapy to treat their opioid use disorder. However, due to the toxicity and potency of the toxic drug supply, as well as inadequate funded support for mental health, it's unlikely that they're going to get to a place of stability where they're no longer using drugs and are in a healthier place. And because of that, they're always going to be at risk for substance use related harms. It's also with, speaking about their chronic conditions, it's going to be difficult to be able to connect with them and let them know about specialist appointments and investigations that are required to be able to appropriately manage their diabetes and heart conditions. Arranging transportation and support for them to attend appointments at a specific date and time can be a huge barrier. And further to that, this individual, like a lot of my patients, have faced significant stigma at the hospital. So attending any care there might be quite triggering and could dissuade them from going to any appointments or investigations altogether. And then in addition to that, following any lifestyle or dietary guidelines necessary to best manage conditions like heart disease and diabetes is often totally unrealistic if you can't afford to buy food or have a home to cook for yourself. So this population of individuals, kind of like this example I just described, needs far greater support and resources in order to come close to the same outcomes as those people with needs. So I do have some specific ideas that we can get into later about improvement in the primary care system that I think could be really beneficial for this population, including recruiting and retaining family physicians and supporting interdisciplinary care teams, improved access to longitudinal mental health care support, virtual care opportunities, as well as enhanced and rapid access to specialists. Thanks, everyone. Looking forward to getting into this discussion.
Wonderful. Thanks, Lindsay, so much. And especially for that, from the outset, acknowledging that where people have different starting points is a great way of thinking where we should all be starting on this. And we'll definitely come back to some of your solution ideas in just a moment. I want to bring Dr. Alan Ruddiman now into our conversation. And Alan, you're joining us from Oliver. I hope you're having some good weather there. But similar question to you, just to get us started and set the table for us around issues of equity that are especially in rural and remote regions of BC, which captures a lot of our province and of course a number of the people who are joining us today. So let me say welcome to you and just give you a chance to introduce yourself and get us started.
Yeah, thanks very much, Richard, and so good to see you all on this wonderfully sunny afternoon in British Columbia. So Alan Ruddiman, I'm a generalist physician, and a generalist physician is largely a family physician that is a catch-all. So over the course of my career working and living in rural communities exclusively in Canada, and 27 of those years, the last 27 years in Oliver, delivering babies, working in the emergency department, the acute care facility, long-term care facilities, doing house calls, running a family practice, and then assuming and taking on various leadership roles and capacities. I should say that I'm calling in and videoing in today from Oliver, which is the traditional lands of the Okanagan Silks First Nations. And I'm an immigrant and settler twice over. I was born in Dundee, Scotland. My parents moved when I was 3 years old to South Africa. I took my medical training in university there, and then I myself immigrated to Canada in 1991 with the opportunity of trying to serve vulnerable populations, underserved communities, but really using my medical degree to be maximally effective. And I thought if I settled in a city, I would probably be constrained in the type of work that I could do. So one of the hats that I do wear, and previously being the president of Doctors of BC and having traveled extensively around the province, we've got a really, really big province here. We've got 26,000 kilometers of coastline. The landmass is bigger than France, it's bigger than Texas, and yet 80% of our population lives and works and is settled in urban and metro communities. But that means that 20% of our population is settled on greater than 80% of the landmass, and yet only 11% of the physicians in this province live and work in rural communities. And that proportion is somewhat similar for nurses and the other allied healthcare professions. So you can see the inequity of the health human resource distribution, which requires us then to, by necessity and design, to work in collaborative teams. And I've really, really enjoyed that part of my clinical career for the last 32 years or so in Canada. On reflection, though, a large amount of resource extraction happens in rural communities. And this fills the coffers of the province. It fills the tax base. And we don't always see the resources flowing back into the rural communities where people choose to live, work, and play. And I'm most concerned about the Indigenous communities. 150,000 plus Indigenous peoples live in small enough communities that they don't even fall into the Rural Subsidiary Agreement, which is a partnership between the government of BC and Doctors of BC in producing recruitment and retention incentives. As we have this conversation today, I want to touch on a number of things, and I'm hoping we touch on a number of things The first is Indigenous cultural safety and humility. We really need to think about the settlers on these lands that go back 10,000 years. There's so much wisdom to be learned, and it's wonderful having Evan Adams here today with us, because there's such a richness and a vibrancy in what we can learn from Indigenous peoples. Healthcare equity is critically important to me, and also quality of care. And I think we're all experiencing on the back end of the pandemic issues around safe care, the effectiveness of care, patient-centered care, timeliness of care, the efficiency of care, and the equity of the care that's being delivered. And so we should be exploring that a bit further. I also want to underscore and stress that primary care is way bigger than family medicine. It's an interdisciplinary approach to how we wrap care around patients, their family members, and their communities. And then I want to talk about the pressures that the digital age is putting on us. We're now seeing medicine go from relational based. I heard that as I was just entering your wrap up of your conversations, to transactional. And I think we need to get back to the core of the human relationship, which is when we invest in one another, when we care for one another, that we're all coming out at the back end feeling enriched in the way we sort of organize and deliver care in the province. And then the last piece I wanted to touch on is the role of health education in our province. I think if we keep centralizing healthcare and health education, we're not exposing learners, whether it's student nurses, student doctors, student physiotherapists, social workers, we're not exposing them to the rich culture that exists in our rural communities. So we can explore that in more detail as we move on. And I think my 4 minutes is up. So I'll hand it back to you, Richard.
Perfect. Thank you so much, Alan, and for emphasizing, this quality of primary care, that it is kind of interdisciplinary in nature. And I know, Lindsay, you mentioned that as well. So I thought if I could continue our discussion rolling, I'm curious, to what extent issues of equity are maybe solvable, or at least a starting point for addressing them, by considering different models of primary care, especially around different kinds of teams or different, practitioners who can be involved in that. If it is interdisciplinary, we need to consider that more. There were some comments brought up earlier around a question of, concern around whether doctors can, in a way, cherry pick patients or choose to serve different communities, and whether a more team-based approach might address that further. So I was wondering if each of you, and maybe Lindsay, I'll give you a chance to start because you were kind of getting us rolling with solutions. What kind of different models around primary care delivery could help us raise the bar of addressing inequities in the system? And then I'll invite the others to chime in as well.
Yeah, so, I think there's organizations like one of the ones I work, Portland Hotel Society, that, have that added benefit of being able to provide supportive housing, wraparound medical care, outreach support, social workers to help address a lot of these inequities and the determinants of health. Although a lot of these organizations rely largely on donations, and it's hard for many of them to stay afloat. And I think that really plays into this whole idea of comprehensive care for vulnerable populations. So many individuals are not in a place in their life where they can manage attending multiple appointments at different clinics, completing investigations. And our patients, as I mentioned previously, have experienced that trauma and stigmatization, which makes it very challenging to get to some of these appointments. So having a primary care provider who is able to treat, like a family physician, their mental health, substance use care, as well as medical conditions is absolutely essential to promote equity. And I think family physicians are really well suited to do this work. However, it's just a huge challenge to recruit and retain, given the compensation models currently and challenges in treating that population. So, of course, a lot of the models of payment can be disincentives, as was mentioned previously, to taking on patients with severe mental health and substance use, given the added time it takes to take care for these individuals. And I know that many of the family physicians who care for the similar populations as I do, with significant mental health and substance use concerns, you do make significantly less, but a lot of us do this because we're really passionate about it. And I think if we want to improve outcomes and support, we need to create an environment where physicians are adequately supported to provide this type of care. So I think, increasing funding for positions in clinics that serve these populations, like mental health workers, social workers, outreach workers, nurses, would really go a long way to improving these patient outcomes, and also takes some of the burden and reduces the burnout from that the physicians experience if they're having to take on all those tasks themselves that, you know, they may not be equipped with. Because I'm not a social worker, I don't understand all those intricacies, but having that team-based care to support someone, just, you know, when I've worked in those settings, I see how much of a difference it can make in the patient's lives. So I think that's just that interdisciplinary team-based care, and the support for that from the government to be built into the system is really essential.
Evan, do you want to weigh into this question as well? I mean, I noticed your example from Hawaii when you were mentioning how doctors kind of needed to sometimes realize, you know, that the obligation to serve everyone and not just certain segments of the community. Do you see a role for expanding our notion of primary care and models as helping to kind of raise the bottom in terms of equity?
Yeah, I'd like to think of primary care, which, you know, is so difficult actually to understand, even when you work in primary care, as a circle of care. A circle of care, there's a circle of care around each of us. And you don't need a very expensive, you know, supremely highly trained physician to be at the center of that. Sometimes, well, I was, for instance, telling one of my elders when I was a younger physician, saying, you know, I'm working in Emerge and it's so busy. We had a, you know, motor vehicle accident, and we had a patient with, you know, stroke-like symptoms, a patient with chest pain, and then the little old lady with diarrhea asked me to go and get her a glass of water. Can you imagine? And my elder said, oh, maybe she thought you were there to help. And it really like drove home to me that the circle of care is incredibly important, you know, no matter what their level of experience is. So let's have a good circle of care. And having worked in interdisciplinary teams like the community health center model, it's really great to have teammates, you know, who can do things that you can't do. Even fellow family doctors, you know, we're trained similarly, but we have areas that we're much better at. Like some are good with younger people, some are good, you know, with the younger female clients, some are better with the elderly who are, you know, who have certain questions. We can't be good at everything. So anyway, I hope that we'll rely on teams much more than we do.
Okay, great. And Alan, let me invite you to join this question as well, and from the rural setting and context about considering this. I mean, as you mentioned, when you came to Canada, you kind of made a choice to not work in the big city and serve communities. And you know, how do you see this question of accepting different models of care that might incentivize you know, raising the bar of equity? And feel free to bring in your question about improving technology in this sector as well.
Yeah, fantastic. I think that's a great nudge and a great prod there. You know, so a couple of things. For those of you that are not familiar, you know, we think about this homogeneous process of delivering primary care to patients and families in British Columbia. But if you look at what models have been dabbled with in the last 10 to 15 years, they're often driven by government priorities. So whether it's, you know, the patient medical home, which is the traditional model that most settlers understand, you know, you have a doctor-patient relationship, you go to a bricks and mortar clinic, and you have a physician that you're attached to that you would identify as your family doctor. Well, this is all starting to become a little bit more fluid. And what I've really enjoyed in rural medicine is, just by the nature of the work that so many of my colleagues do, we're obliged and required to work in collaborative teams, either in the hospital, in the community interfaces such as, you know, nursing homes, care facilities, but also when we do house calls. And especially for those of us that teach, we often have medical students, residents, nursing students who are in our communities any given time. But, you know, some of the other models that have been dabbled around would be, you know, primary care networks, which we see have had sort of relative success depending on the part of the province you're in. And then, of course, when people weren't gaining access, the next thing that got thrown out were urgent primary care centers. And then the default, when you've got no access, is you show up at the emergency department. And in a small rural community, you're often the same person seeing the patient in the community or the emergency department. But emergency rooms are hazardous places. I have to say this. They're risky because you may end up seeing a team that doesn't know you, doesn't understand your history, doesn't understand some of your social and economic challenges. And so it becomes a bit disconnected. and I have to say, you know, Evan has flagged what I would say is probably going to be the ideal model for British Columbia moving forward, which is the community health clinic model. Because again, you know, primary care is not the domain of family physicians alone, nor is it only the domain in medicine of family doctors. I think about my pediatrician specialist colleagues. I think about psychiatrists. I think about general internal medicine. A lot of these physician specialists are managing on a day-to-day basis, sometimes in collaboration with a family doctor and a patient, but sometimes on their own, are really dealing with the primary care needs of their patients. Think about this now. My capacity in any given day to see patients so that they're heard, you know, you can say I'm having trouble peeing, and or I've got this cough, and by the way, what about this growth on my foot? You know, to create the time and the space to do that, to look at a patient as a whole, does require time and energy. But if I allocate 8 to 10 hours of my day to do that, I might have 25 to 35 very meaningful patient interactions. Now, imagine if I have a team that wraps its care around, we can get around 200 to 300 interactions as a team, some of those in person, some of them over the telephone, some of them by video conference. And these can be done synchronously, so in real time as we're doing now, or they can be done asynchronously, where I communicate to another member on the team who might reach out to 5 other people. So I think we have the resources in the province to look after 5.1 million people really, really well. I think we have the economic resources, but I think it's the lack of coordination and establishing a common vision for how we want to deliver primary care moving forward in this province, so we leave nobody behind. So do we do it really well in Oliver? We probably do, but I have a bias. Do they do it really, really well in Cranbrook? Ask the people who live in the catchment of Cranbrook. And so I think we're going to have to stylize the delivery of care based upon community need, because no two communities have the same population mix or the same identified needs. The downtown east side has a very different population mix than my community in the South Okanagan, who are often very frail, elderly, and people on fixed income. And they have some of the most amazing health conditions that act as a hotbed for teaching if we can get people into our communities to put roots down. I'll just touch on one other piece really quickly. You know, I think every ministry needs to consider itself as having an impact on health, whether it's the Ministry of Transportation, whether it's a ministry looking at technology and innovation. And so I just want to reference, particularly for Indigenous and First Nations communities, the tremendous impact that the digital divide still has. If we cannot get broadband, high-speed internet into communities to support learners, to support students, to support people who feel physically and emotionally isolated, but also the ability to connect their providers to them when they can't see one another in person. If you've got high quality fiber optics, this really is a way for bringing us all closer together. So, you know, we've rolled out and supported a process in rural BC called real-time virtual support that we accelerated through the pandemic, so we can connect family doctors to specialists in other parts of the province. We can connect patients to specialists, and it can be done as we're doing now at the touch of a button. If it's possible for rural, it's possible that it can be scaled to the rest of the province, but it needs to be relational. We need to have these foundational relationships, which is the last piece of the puzzle for me. I think we need to democratize electronic medical records so that all patients, regardless of where they live, work, and play, or how they move around, have access to their personal medical record in real time, and so do the accredited providers that are trying to provide care to them in an emergency room, in the community. You need to see your information as and when it happens. It needs to be real, relevant, and up to date, and that'll reduce risk and hazard in the healthcare system. So I think there's a tremendous opportunity for industry as a linked sector to help us with the innovations that are necessary to deliver those, so that we as doctors and nurses and physiotherapists and social workers can get back to what we do best, which is providing patients and their families with high quality care that they deserve.